Good morning. My name is Paul Devlin. I'm the Trust Chair at Nottinghamshire Healthcare, and welcome to our board meeting. Whilst it's the 1st of February, this is actually our first board meeting in 2022. It feels rather late to say Happy New Year, but the sentiment is there anyway. So you're very welcome joining us either live or indeed watching on catch up. So, as always, we start our board meeting with a patient or staff story. And today we're doing slightly differently for various reasons. We've got a video that of a patient that we want to share and then reflect on as a board. And this is a woman called Marie who's had experience of our podiatric surgery. And is going to be talking about her experience. So if we'll move to that tech, to the tech for showing the video, just to say that as ever with these online things, that if the video may get a little wobbly, but the audio will hopefully hold out through it. And it's about 15 minutes or so. So if we could roll video, please.
Well, I was sent to podiatry because I'd got a foot like a duck and pain. I was hobbling with my hip. Met Mr. Harmer and he was lovely. Told me he'd get me back in my shoes. I thought that'll do. So I went into he came to community. I went in there and he examined me and he sent me for x-rays and he says it was bad. And I didn't think it was that bad, but it was. So he organised for the operation. The due date came. I passed my test. It's the only time I do a COVID test. And that's when I met Mark. He's one name I remember. I'm terrible at names. And he did me tests and everything and talked to me and got me history and put me at ease. Came day for operation, 31st of June. I went in full of nerves, went into reception, they were absolutely brilliant, sat me down, sent over to the next reception, put at my ears again. I thought, she took me to the left, put me in it, told me that there'd be somebody to meet me at the other end when doors opened. They opened. I'm terrible at names. There was this lady there. After multi and biscuits, you know, you can have a cup of tea anytime you like. You know, just ask us. And they were all chatting and helping one another and still doing their job. And you could see them doing their job, but you weren't forgotten. You weren't waiting to go in. You know, they were chit-chatting to you. And then I was taken in, and Mr. Armour were there. And there was this other doctor, or nurse, a male nurse, I don't know. He was a big guy, and he were lovely. Even he chatted to me. Screen were put up, but I could see his face. And he's deciding on, because I've got skin problems, he was deciding on which one antiseptic to use. And to have somebody wash your foot with this antiseptic and leave you your dignity. That's what I felt. And then we had the operation ongoing, and a nurse came and held my hand. She had time to hold my hand. I was so grateful of that hand. She was lovely, chit-chatting away again. Mr. Armour were talking to me, that the team was working. I was aware of them working. I was interested, not frightened anymore.
Yeah.
I was amazed by it. And time flew. It took them no time at all to do a first-class job. And they all left the room. I said, is it something I said now, X-rayed? And they come back laughing and joking, but straight on job. You know, no discomfort and no pain. At no point were I frightened. And my nurse was back, and they were doing their jobs, blood pressures and everything. The jobs were being done, but you weren't being frightened by them. The care were there, and they were anticipating one another, as I say. Nuts, bolts, screws, you know, machinery that they were having to operate, things they were having to do. There was still an air of calm, but not antiseptic. It was natural.
Yeah.
And it was so, I thought, why were you frightened? Why were you frightened? And I was rigor mortis frightened. And then the training officer, I want to go back, had told me that if my daughter needed any guidance, just to ring. I'd got all the numbers, I'd been given all the paperwork by Mr. Armour previously, and we'll talk to her. Anytime she needs any help on looking after you, she's only to ring. Now that were a reassurance for somebody that were even more rigid than I was and waiting in a car park down the road. And basically they were brilliant. And going back, when the operation was over, I was brought out and into recovery, and I was given more information, and I was surprised that I was able to take it on board. Little tricks on my recovery, how to actually put your feet up on a pillow. It's a technique, and it works. Oh God, it works. And where to put an ice pack, I didn't know. I thought you just put them on the swallow bit. Yeah. It's a technique. And I was taught their knowledge, and it went in first time. And I were able to relay it. I didn't need to relay it. In the few minutes, I'm jumping ahead, in the few minutes that they spent helping my daughter get me into the vehicle to come home, they trained her in where to put the ice pack, how important it was for me to have certain medications that I was sent home with on time. She's technically able, and she set her phone up so it beeped, and you know, she was there with a glass of water, and you've got to drink it all, and you've got to have 2 litres of water, and you've got to have this. But she didn't miss a beat.
No.
But they took the time and trouble to train my carer, and I didn't have to think.
Yeah.
I'd also got it written in sheet form, and she'd got her log and double checked that she were doing the right thing. You're having them because they said you needed them for so many days, so you're having them, because I'm not a tablet taker. And she made sure it went in with the appropriate amount of water per day. It's no use having experts and doing it yourself. And I didn't have experts, I had a fully functioning team. I laid there, like Lady Muck, and counted them. There were 9. And everybody had a place, and they were in the place, and they did their job. But they didn't forget me. Not for a minute. And basically, that put me so relaxed. And I owed it to them to follow letter at law on exercising, all of which were printed out and given to me before the operation, so that I already had them at home and could look at them for what was to come and train myself up and think I won't be able to do that. No such word as won't. You can. If I can do it, anybody can. But it's only because they told me how to do it. And little tricks. I mean, you think an ice pack's an ice pack. No, it's not. It can work better than drugs. And it really did. Because when I was first told that, I thought, nah. And yes, it was true.
And how are you now?
I still can't tap dance, but I couldn't before. But Mr. Armour said I'd have a scar. Not with a maestro like him. I mean, his sewing skills is beyond belief. And I am able to, I've cleaned cupboards out that I've been able to clean out for 3 years. I've been able to garden. I haven't been able to do that. I've actually had to hire somebody. I've had to delegate so much of my work and pay people to do it. I may be 71, but I'm not past it yet. I still work. And, you know, I was paying people to do jobs that I could do. And it's cost me a lot of money, as well as a lot of frustration. But the best bit, when I got up onto my feet just to go to the bathroom, onto my foot to go to the bathroom with crutches, I've got the trainer's words in my ear of how to do it safely. And she'd even taught me to turn round with crutches. Now, I wouldn't have thought of that. It was fine tuning. It were teamwork. Of one looking after another's skill. And basically, I'm just overwhelmed by how that team mustn't be broken up. They work too well together. It'd be a big loss. But if there were more of those places, they've got to be on like that basis, because I can guarantee that the atmosphere is beautiful, calming and caring. It's a team with capital T-E-A-M.
And if you were to summarise with the one thing that you feel really made the difference for you, the thing that had the biggest impact in your care and then your recovery, what would it be?
That I know I haven't got to have a new hip. I've no pain. I thought I was going to go on for operation number 2. I don't need a new hip. There's nothing wrong with my hip. But the pain in it was sublime, is the way I can describe it. It was, I was losing sleep. I would not only work, I was losing sleep. If I got 2 hours without moving in bed and being woken up by pain, not in my foot, in my hip. And I thought, no, it's a fluke, the first time I went to the bathroom. And then I said to my daughter, I says, I think, because she said to me before when she was driving me there, she says, it'd be ironic if you got two for the price of one and didn't need a new hip. And I says, I love your optimism. It wasn't optimistic, it was fact. So I really didn't realise how bad I was. I knew I was bad, but I didn't think I was that bad. I can climb stairs for the first time in 3 years. And I do properties, and it's important for me to be able to check and inspect houses.
And so if you wanted to get a message to that team, and I know you've already spoken to the team, but if you wanted to convey to the board one message for that team or about that team, what would it be?
You can't improve on perfection, and they're a perfect team. Everybody knows where they're supposed to be and what they're supposed to be doing. But every one of them took time to speak to me. Every one of them took time to care for me, and I do mean care, and relax me and make me feel safe. And nothing was too much trouble. And I'm thinking, this isn't real.
Thank you, Marie.
Great, thanks very much for sharing that video. And Marie, thank you for taking the time to share your experiences. It was really good to hear about the team working so effectively together and their clear patient focus and a focus on your independence and self-care. Becky, can I just invite you briefly just to put a bit of context around the podiatry service that Marie experienced for us, and then I think colleagues will take from this and move into the board meeting itself. Becky.
Of course, Paul. Good morning. I'm Becky Sutton, Director for Community Health Services, and what a fantastic story from the patient. It's great when we get everything perfect. So just for context, we run a whole range of podiatric services, podiatric surgery and community podiatry across all of Nottingham and Nottinghamshire. I think it's quite a unique model, that it's a fully faced community model, and we're privileged enough to have two podiatric theatres over in Park House, and we do a whole range of different surgery, from bunions to nail extractions, all the way through to bone operations, for want of a better word. So it very much bridges on the work that orthopaedic surgeons do as well. So full team of podiatry consultants that are consultant AHPs, podiatrists by background that train through to do the surgery, and I believe they've been running the service for tens of years, so goes back into the 80s that they started the service off, and you know, a great story and great feedback from the patient around the way the team works. It's a wholly owned team by Notts Healthcare, so that includes the nurses, as I say, the surgeons, as well as the support staff. And I know a number, I haven't got there yet because of COVID, but I know a number of the execs have been and seen it in action, and it's pretty impressive. So hopefully that helps, Paul.
Thanks very much, Becky. And I think you've really underscored the importance of that team. And I think for the rest of our meeting, colleagues, if we can just sort of hold on to that image of Marie, particularly her personal move from being really quite scared about what was going on for her, and actually to being that independent person herself. I loved that she was no longer delegating to other people. So really excellent. The training and education that came through really helped her get back to self-care. So thanks very much for that. Thanks to Amy Gaskin-Williams for going out and making the recording for us, Amy. It sets us in a good place for our board meeting. So, colleagues, if we can move to our formal agenda, please. And in terms of welcomes and introductions, I'd like to welcome Alison Wild, who's stepping back in actually as the Acting Director of Finance. Alison, good to have you back in around the board table with us. And whilst not on screen, I'd also just like to acknowledge Aidan Dominy. Aidan is shadowing Chief Executive John Bruin as part of our parallel learning work and parallel mentoring work. And Aidan, you're very welcome observing John in the context of the board meeting. I know it's something that he will then follow up with you on in terms of the experiences that you've observed. So we can move to apologies for today, and we've had apologies from Manjit Darby, one of our non-executive directors. I don't think we have any others. So our declarations of interest, just to say that the declarations, the register is obviously kept up to date. Have anybody got any declarations of interest specific to items on the agenda for the first part of our meeting today? Okay, I'm not seeing anybody identify any today. Thank you. In which case, if we can move to questions from the public, and just to say that we've had some questions from a member of staff who's raised questions with the board on previous occasions on aspects of our response to COVID, to vaccinations, and indeed actually had been asking some questions about the at the time of writing the mandated the intent of mandated COVID vaccinations and some other aspects in relation to the use of protective equipment as well. John, I know this has been quite fast moving indeed in the time since the email came in. So do you just want to give a brief response and invite anybody else in who can add to that for us? Thanks.
Yeah, thanks. Morning, everybody. John Bruin, Chief Executive. With regard to the mandatory vaccine and with regard to PPE, I know that both Claire Tini and Anne-Marie and you may want to comment, but I think these are broad brush comments really in relation to the question. As you say, Paul, things are moving on very quickly at the moment. I think one of the main concerns, both from the person that sent the question in and from a number of our staff, has been about the vaccination, the COVID vaccination being mandated as a condition of employment, and that from Thursday, unless you'd started your vaccination course, you wouldn't be compliant by the 1st of April when the legislation was going to come in. However, and as people will have seen, there's a very large however, that the government has now said that they will not be pursuing that mandated COVID vaccination as a condition of employment, which is a really massive change in terms of the plan around vaccinations. So that's the first sort of point to make, and that was only announced in the House yesterday. So there's an awful lot of so what questions that may accrue following that in terms of, okay, so what is the plan then? But I'll just add that in terms of where we are, we've had a really strong uptake of vaccination across the whole trust. So we know, for example, that over 96% of all our fantastic staff have had the first dose. And it's high 80s, it might even be early 90s now for the booster. So that's tremendous. In terms of, okay, what's our stance on where we go from here? I think the well, I don't know about the vast majority, but I think there's a growing consensus that mandation wasn't the right approach. Vaccines are really, really important, and they save lives, and they enable so much of healthcare provision to continue in a safer environment. And we'll continue to use a risk-based approach. We'll continue to enable people to be as fully informed as they possibly can be in terms of making a choice about taking the vaccine, and we'll continue to support staff to take it where possible. There are obviously different clinical and non-clinical environments where the risks are different, and we need to take that into account too. So the summary piece on that is it's rapidly changing. There's been a significant change of policy, and we'll continue to pick up and keep staff informed of where we go from here. The final bit on that is just to say that we're still in essentially an incident level 4 command environment where I get quite a lot of emails saying, you know, why is the trust taking this up? It's not a choice, and we are told to comply. It's not for a conversation or a debate. We do push back regularly on things that we could think could be improved, but that's where we are on that at the moment. I don't know whether Claire wants to come in from a more of a sort of HR perspective on that. Thanks.
Claire?
Yeah, thanks, John. So yeah, the position that we're in is that up until yesterday, we were working in compliance with what is and still currently stands as the legislation around mandated vaccinations. And then the announcement yesterday is that there will be a further consultation around that approach. So there'll be a consultation, and the responses to that consultation will go back to Parliament. So in the interim, what we are continuing to do is 2 things. We are continuing to support conversations around obtaining a vaccination, and they are still available to colleagues, but that isn't something that we'll pursue down a formal route of mandated at this time whilst we wait the outcome of that further consultation. The second thing that we will continue to do is validate the records of colleagues where it's not clear if they've been vaccinated or not. So for a small number of colleagues, if they've received a vaccination overseas, if their name and address doesn't exactly match the staff record compared to what's on the immunisation record, we can't see the results of that. So we will continue to validate records and information, and we'll continue to have supported conversations with colleagues during this period until we're at a point where we receive any further guidance. So that's the current position that we're at based on yesterday's announcement around a further consultation. Thanks.
Thanks very much, Claire. Thanks, John. And just to acknowledge that we have continued to have teams of staff working really hard to support both the vaccine rollout, to support the staff engagement, and indeed to have put in a lot of preparatory work around the potential introduction of the mandatory programme. And as John says, this is responding to directives that we do have to comply with, but I really do appreciate the hard work that has gone in, and we will continue to have those conversations as Claire has identified there. Just to also say, whilst these questions have been raised with us as a board, I know that the executive team will be continuing to engage with all of our staff about how both the vaccinations and the wearing of protective equipment may develop and change over the coming weeks and months, and that's conversations that continue to be ongoing. So thanks very much for that. Let's move on if we can. So first off to the minutes of our last meeting. Can I first just get an indication from colleagues if you're content with these minutes being an accurate record, please? If you could just give me those indications. Thank you very much. And if we move on to the action log that is there, we've noted that we moved a board development session to a little later in the new year, in part in response to the command and control situation that John had referenced. But other than that, I think that we are up to date on matters arising. So if we move to my report, just a couple of things that I wanted to do. I do want to reflect my personal thanks and thanks on behalf of the board to all of our staff and volunteers for the work that you've done throughout the period since we last met back in the beginning of December. That period of December and January was as intense as I think anybody can remember, and massive impact of particularly the Omicron variant on both workforce and indeed on our staff and colleagues, families, as well as those using our services and knock-ons from that. I know we'll hear more about that during the board meeting, but I just wanted to give a very strong thank you to everybody for their work, particularly over that period. It's been incredibly intense and came on the back of the previous 2 years as well. So thank you. In terms of my report, I'll take it as read, apart from just being at this stage now that we've had the Council of Governors meeting that had confirmed the non-executive director new appointments. I just wanted to place those on record, and we have 3 new non-executive directors who will technically start with us tomorrow, and they are Fiona Daniel, Nigel Smith and Paddy Tipping. All 3 bring very different experiences and will bring great contributions to us as a board. And then in a few months' time, Sue Sunderland will be joining as a non-executive director and indeed chair of Audit when Stephen Jackson, our current chair of Audit, his second term comes to an end in the summer, and there'll be an overlap then. So warmly welcome all 4, and very much look forward to getting you into the board and into the trust. And then my final piece was just to acknowledge the task that I had with some colleagues around judging for our staff recognition awards. As I said in the paper, it's a great challenge to have to plough through over 400 nominations, and it was a real privilege and quite humbling to read of all of this great work that colleagues and indeed those using services wanted to reflect on as part of our Oscars and staff recognition awards. So I'll just pause to see if there are any comments or questions on my paper. Don't think there will be. No. So John, if we could go over to you, please, for the Chief Executive report.
Thanks, Paul. Hi again. So take the paper as read, and there's actually not an awful lot of content in this month, largely on account of the pandemic. It's been full-on action stations as described in the executive summary. A number of us have been around quite a long time, and I think it's true to say that over Christmas, New Year and the first couple of weeks in January is probably the most challenging time many of us have ever experienced working in the NHS and care system, and to acknowledge the amazing professionalism and resilience of our staff and volunteers across the whole organisation, across the whole trust, to keep the show on the road. And it's really important to recognise and acknowledge that and say thank you. We're clearly not out of the woods, but the very high pressure, particularly around staff absences, and demand in the first couple of weeks of January has now passed. A couple of other things to say about that, really. I think it's important that there's a whole stack of learning to take from the pandemic and the various waves and difficulties that we've managed through. But one of the important things is not to think that Omicron was the only reason why things have been challenged. If we think back to October and November, for example, before Omicron became a word even, we were really stretched then across a number of different fronts, particularly in terms of our staffing, our retention, recruitment, and covering off services, and managing the very significant increase in demand across a range of different sectors. So it's important for us to not lose sight of that. And then the other thing is looking the other way in terms of looking forward. It's clear, isn't it, on a lot of the charts that we see that the numbers of COVID cases are falling quite significantly, and certainly the severity is much less. What the future holds is difficult to predict, but we do know that there's a huge amount of NHS transformation coming down the line. Yes, some of it's been a bit delayed, so some of the integrated care system formal legislation has been put back from April till July, but it's not going to go away, I don't think. And within that, there's a huge amount of transformation, and I suppose you could look at it two ways. One is that that's the last thing we need. We need to get through this, recover, and pick things up again. But at the same time, you could say, well, actually, it's a perfect opportunity to look at some quite strategic transformation, not just within the trust, but within the system. Of particularly if you look at things from a patient perspective in terms of patient pathways and the inefficiencies and bureaucracy that we have, and now would be a good time to look at that. So that's ahead of us, and important not to lose sight of in terms of what is our trust stroke organisational input into that. What's our leadership? What are the things that, in terms of our culture and values, we'd like to see, worked into a sort of the DNA of the system as it becomes a real thing and starts to function and be responsible for services, but accountable for outcomes. So that's the last bit of the executive summary there. In terms of the paper itself, Paul, not very much to say. That there's bits there on the CQC and where NHS EI is in their sort of priority areas at the moment. Just a little bit about the CQC, the Care Quality Commission. We have regular engagement sessions with them. They've announced, haven't they, a couple of days ago, that they are starting their national inspection programme, which had been suspended for a number of sectors, and they're starting that again today. But we also know that they've been in mental health and community trusts in recent weeks and months, and they use what's called a risk-based approach. So if on their dashboard that things start to flash red, they'll come and have conversations with trusts, and we'll also do some targeted inspections, and we suspect that for that reason, and for reasons that that they haven't been here for a long time, and that they will probably be coming fairly soon. So we're going to start a programme of work to refresh a lot of the preparation that we did last year. And then in terms the rest of the papers there for people to see, I'm happy to take comments or questions. Thank you.
Thanks, John. And I know colleagues and teams are really looking forward to being able to re-engage with the Care Quality Commission, and just to share how proud they are of the services that we have got, and the way that those have continued to develop and transform, even within the last couple of years. And just to acknowledge that, of course, you've marked a number of really important celebratory pieces acknowledging and recognising staff and teams. So I'll pause for a second to see if anybody wants to pull anything out from John's report. Again, I think some of the detail around things like the staffing, etc., will pick up in later items. So, okay, I'm not seeing any flags for that. So thank you, John, for that. And Alison, if you could introduce yourself and the integrated performance report. And I know you know the usual steer that you can give with your executive colleagues. Alison.
Thank you, Chair. I'm Alison Wild, Interim Director of Finance and Estates. I forgot my title then for a moment. So thank you for today. So I'd like to present to the board the integrated performance report for the period ending the 31st of December. That's month 9 of financial year 21-22, and it's presented to the board for assurance. Just to note, it's a slimmed down version of the usual board performance report due to the reduced reporting during the current level 4 pandemic. It is worth noting, and I know that yourself and John have covered this in your presentations, that during December, the period that we're reporting on as a trust, we're at the height of the pandemic wave, and it's reflected in the performance overall in the report. So what I'll do is I'll ask the operational leads to comment on their areas, and I'll take that in the order of the report, if I may. So I'll hand over for quality. Thank you.
Thank you, Alison. My name is Anne-Maria Newham. I'm the Executive Director of Nursing, AHPs and Quality. I'm also something called the DIPSI, which is the Director of Infection and Prevention and Control. And as you can imagine, I've been fairly busy with that role. So firstly, I'd like to take you to the bottom of page 22 or number 2 on your reports that you can see. And this is around wards with safer staffing rates that have been lower than 85%. And as Alison says, we've been in level 4 pandemic, but that effect has then been on safer staffing rates too. So we've had a real reduction in the amount of staff that have been available to us, both substantive staff, but also some of our temporary workforce, which we call agency and bank. So the number of the wards in the trust that have been experiencing significantly low staffing has seen a 6th consecutive month of high levels, with 16 wards reporting staffing below 85%. Now that is a concern for us, because it means then that certain activities may need to stop. We can't do as much with patients as we would like to, and actually that can affect some of their practices around open air and being able to get out and about. The forensic division is again the most affected by these staffing levels, accounting for 11 out of those 16 wards. Staffing challenges within the division remain a major pressure and are concentrated mainly at Rampton Hospital. But I have to say, Rampton has been absolutely fantastic. The staff themselves have really rallied and supported each other. People have been doing additional hours, extra hours, coming in on their days off, and really showing up and helping out. So that's the first area within quality I just wanted to mention. And the second one is around how many actual patient cases we've had of COVID. So there were 110 COVID cases reported in our month 9 report, which is December of last year. And that is a high number of patients having COVID. Our average before that was 20, and we've had 110 in 1 month. So that spike has caused a lot of impact for us. It means that a lot of the wards have had to close. We've not been able to have the flow that we would normally have. And 87% of those 110 cases met the criteria for a healthcare associated infection case. Now, what that means is that we use the word nosocomial, and that basically means that the patient became infected post being in hospital for 8 days, which means that they became infected whilst they were in our care. Now, we've also had an awful lot of staff that were affected as well and have become positive. We saw a lot of reinfection rates over the period of December as well. So those are the 2 areas I just wanted to highlight out of this report today. Thank you very much.
Thanks, Anne-Maria. Let's just pause. I I've got a question myself, but let's just see if anybody else has got any questions or comments to bring out. Sue Nixon.
Thank you, Paul. Sue Nixon, Non-Exec Director. Thank you very much, Anne-Maria. Given your last comment about those infections that may well have been acquired on our wards, could you highlight the type of work that we're trying to undertake to address that in the future, to minimise that, please?
Yeah, so we are maintaining our position, and actually this comes up to a point that Dr. Bruin raised earlier. For us in healthcare, it's still about wearing masks. We have introduced visors where we have high transmission areas. We've introduced FFP3 masks, which is an additional mask that gives additional protection in high transmission areas. So areas that have got, for example, poor estate where they can't do as much ventilation, they can't open the windows up as much. So these are all the things that we're maintaining. So masks, visors, ventilation. We've maintained the 2 metre social distancing as well. And we're just really reiterating with staff all the time that they are there to care for our patients, but care for themselves as well, and still to take all those to maintain all of those precautions when they come into buildings. We call it something called donning and doffing. You might have heard that in the media, but donning and doff is when you take all your kit off, you put all your kit on, and it's how you do that, and you make sure that you're not transferring the virus from clean kit to dirty kit and dirty kit into clean kit. So these are all the things that we are putting in place, and there's been a lot of work. We've got to make sure that we've got stations for people to be able to clean their hands on a regular basis. We make sure that we don't congregate into spaces. We've had to help people as well a little bit about their social interactions, what they do over Christmas and what they do over New Year and what they do around parties. So we've had to sort of like say to people, please be careful, because that's another area that we're transmitting. So there's lots and lots of things that we've been doing so in order to reduce the risk of infecting any of our patients.
Thank you, Anne-Maria. Oh,
Carolyn, have you got a question? I think Paul's frozen, so yeah, so do you want to ask me a question? Yeah.
Thank you. Carolyn White, Non-Exec Director. And Maria, my question is around the staffing. So you've explained very clearly why we've got some of the challenges. I just wondered if you would elaborate for us, please, on what the plans are to try and improve that situation, because clearly having patients in forensic services who aren't able to access therapies on a regular basis and things is not good for their progress, but also in terms of the broader issues. You said that in your report this has been going on for in excess of 6 months now, and I just wonder if you could, elaborate on what the plans are to try and improve that situation.
Yeah, we have got we've got some short, medium and long-term plans. One of the medium to long-term plans is around international recruitment. We've just been successful with a bid to NHS improvement around funding a small team of people to help us to recruit nurses from abroad. And our ambition is 50 nurses per year, and we're already starting that programme. The adverts have already gone out for that. Now, our partners, so for example, Sherwood, they've been really successful with that. They've brought in 127 nurses recently, so we're learning from them. We've also got them advising us about how they did it, what pitfalls, what to look for, what the successes have been for them, and how we develop that. So that's the first thing we've been doing. The second thing we've been doing is that also, again, it was a national programme around introducing and improving the recruitment and retention of healthcare support workers, and there was again funding that was available nationally to increase our healthcare support worker workforce. Now, we are quite good at that in this trust, but actually it was more of an incentive to try and get back out there to do that retention and increase our recruitment of that as well. And we've done loads and loads of work around that, and we've increased our healthcare support workers. We've also introduced some new roles as well. So we've got advanced clinical practitioners, we've got nursing associates. We're also discussing with the university about how we can increase the students that we are getting as well. We've just increased our learning disability students, which is the first time we've increased that for a long time. So our relationships with our partners in respect of placements into the organisation is something that we're discussing as well at the moment. So I could go on because there's quite a lot. There's not just one answer, but there's an awful lot there. I've just mentioned 3 or 4, but there's loads more that we have been doing as well.
Carolyn, do you want to respond?
No, I just want to say thank you, because I think that really helps in terms of context of actions that the organisation is taking. Thanks, Anne-Maria.
Yeah, and just to underscore that, that was certainly one of the areas I was concerned about as well, Anne-Maria, the kind of the underlying challenges versus the challenges that have come particularly from Omicron. And I know when we get the forensic section of this report, we'll hear a little more about some of that work. But it's just really important that we are working really hard at tackling those underlying issues, and that our staff know that we are working hard at those. This absolutely isn't just about Omicron and other variants of COVID. Trevor, let me bring you in now that I've been able to reconnect. Trevor.
Thanks, Paul. Trevor Orman, Non-Exec Director. Anne-Marie, it's a fairly basic question in two areas. One is COVID and the other is shortage of staff. Are we in family with other trusts, or are we a better or worse? Just so that I can get an appreciation of the scale of what we're dealing with compared to what's happening nationwide. Oh, in respect of absence, you mean, Trevor? Well, in terms of either absence and or shortage of staff. Yeah, yeah. It's more. Yes, sorry, it's more absence. Yes, you're right. Yeah, yeah. Yes. No, that's absolutely fine. We are on a par. And interestingly enough, we did a bit of a recce with our other 2 high secure hospital partners, and they had exactly the same. Now, we were a bit of an outlier. I have to admit that we were a bit of an outlier with the amount of COVID outbreaks that we had, which did affect then how many staff were off. But when I spoke to, for example, Sherwood and Nottingham University hospitals, they had equal amounts of absence, but they didn't have as many outbreaks. So I think the outbreak situation did affect us quite a lot at that time. So the whole of December and the beginning of January did affect us with regards to it, but we were on a par with our high secures, and we were on a par with our mental health partners in Derbyshire, Nottinghamshire, Lincolnshire and Leicestershire. Thanks, Emily. I know it's a basic question, but it's really important that we are able to correlate where we are. Yeah. Because if we are an outlier on the negative side, then we've got some serious issues. But that's a very, very comforting response. Thanks, Anne-Marie. Thanks, Trevor. I think, Alison, we can go back to you to steer us on, please.
Thank you. I'd like to pass over to the section on people and culture, please, now to Claire.
Hi, morning everybody. Claire Teeney, Exec Director of People and Culture. I won't cover off some of what's been already said, but just to reiterate the point around the point that this report covers what I think was some of the most difficult periods that we've experienced around the pandemic, and that's due to a cumulative effect and what came about in terms of a highly transmissible variant. And just to sort of remind everybody that throughout this period we went into what would normally be our winter, but our winter actually started in summer and has continued throughout in terms of our capacity planning, our demand and the pressures that we've had around some of our workforce, which has just been discussed in the section prior. We did hit some of our highest total absences in terms of sickness absence leave and absence related to COVID. They're the highest that we've seen throughout the whole of the pandemic, touching nearly 11%. And by the time that you added in much needed annual leave on top of that, it did reduce our overall capacity significantly, and therefore, as we've just described, we have had to adjust the way that we work in particular areas quite significantly. Fortunately, that hasn't been for a sustained period of time, and we have started to see that settle down now. So we are back to sort of overall absence at around 8.5%, but that is running higher than we would ever expect it in a winter. So whilst the position's recovered, we have still got quite significant numbers of staff that are out, and we are supporting and managing that as best we can. And some of the way that we're doing that has just been talked to. What we're also doing was the last conversation was really around recruitment, retention and capacity. We're also continue to support our colleagues with a health and wellbeing offer, and I am pleased to report that that in January we did see the launch of our in-house occupational health service. That's been planned for 12 months, so that does had significant capacity in terms of the support that we're able to give colleagues and managers that work for Notts Healthcare. So that's a really good move for us and a positive move for us. So we were able to keep that to time. It was planned for January, and we were able to continue to do that without any delays. That's really important for us, and we continue to build on the health and wellbeing offer to support colleagues. We have had in place derogations around appraisals. They remain in place until the end of January, and we'll start to pick those up now, so those appraisal conversations can happen with colleagues. We've talked already at the board about vaccinations, so I won't re-rehearse what's already been said. It is an evolving situation, and we are waiting to receive further national guidance, but vaccines do remain available to colleagues if you haven't had them and want them. And we will be picking up records, as I said earlier, where we cannot see the vaccination record. And the situation around vaccinations will evolve throughout this week and the coming weeks, and we'll keep a watching brief on that and communicate out accordingly. There wasn't anything else particularly for me to add. I think it's been covered by Anne-Maria's update. Thanks.
Thanks, Claire. I've got a comment. I'll just invite others in first, just to see if anybody else wants to come in. Yeah, Sue, you come in first, please.
Thank you, Paul. Thank you, Claire. Sorry, Sue Nixon, Non-Exec Director. Thanks very much, Claire. This is a question actually to you on the back of the comment that Anne-Maria raised, where she was talking about the international recruitment and various other approaches, and suggested aiming for 50 new posts to be filled. How realistic do you think that is to achieve? Is my one question. I'll come back and ask a second if I may.
So that really depends, Sue. So we know that that's an ambitious target around mental health nurses, and that's really unlikely. We are hopeful to get registered general nurses who have experience of working with mental health patients and in mental health settings. So we're hopeful to retrieve to attract a realistic number around that. In terms of general nurses, it's a reasonable target to aim for, because we do know that other trusts are able to recruit up to and in excess of those numbers of registered general nurses. So the market is out there. It depends on the level of experience and qualification that we believe that we require upon assessing those candidates, and what sort of wraparound and support capacity we have to give to get colleagues up to speed to be able to work in mental health settings. So it's a bit of a long-winded answer, because it will vary dependent upon what we can do around capacity and support in terms of placing people in our trust.
Sue, do you want to come back on that and come to a second piece?
Well, I'm mindful of how difficult it is, Paul, but I just felt it was important that the board understood the approaches that Claire and others were looking for. So thank you for that. My other was a comment, actually. I just wanted to say congratulations in terms of bringing all the health and wellbeing support in-house. That's been a huge piece of work, and that's excellent to do that. I'm just wondering what the take-up has been already. I know it's only in its infancy, and it's probably a bit of an unfair question, really, given it was only on the 1st of January. Have there been any problems in setting things up, and what has been the take-up as far as you may well be aware?
So the transition to bring the occupational health service in-house has gone really well. The colleagues that are actually working in that service started working with us at least 9 months ago. So they've been working for Notts Healthcare on the transition of that service. I haven't got the stats in terms of the take-up, Sue, but I can bring some of that detail through, and we will do to the next People Committee. Yeah. In terms of overall sort of contacts around the health and wellbeing service, we do receive in excess of 9,000 contacts and interventions that we've supported in a 12-month period. So that gives you a bit of an indication as to how responsive the service is overall, but very happy to bring through some more of the detail to the People Committee.
Claire, could I just add in on the back of Sue's first questions and your comments just around the staff sickness piece, just acknowledging, as you've said there, that actually staff sickness has had an increasing trajectory actually right from the beginning of the financial year, and I did just wonder whether there's any correlation we need to be alert to, where perhaps towards the end of the previous financial year, we'd been in a position where staff were able to take time off for holiday and recuperation time, and whether there's just the pressures that have built up during the year mean that has been more challenging. I don't know if you'll be able to give an answer to that right now, but it's perhaps something that you could just make sure that we are considering in the round through the People Committee.
Yeah, thanks Paul. There's no we continue to look at it. There's no necessarily direct correlation with people being off because of not necessarily being able to take annual leave. We tried to manage that throughout. It has been challenging, but we have tried to manage that. We are concerned about the cumulative effects, though, of people having disrupted personal lives, disrupted work lives, not being able to do the job in its fullness necessarily that they are employed to do. And of course, in some cases, people redeployed for protracted periods of time to support other services. And it's the cumulative effect of those things that we are watching and trying to support and trying to manage and trying to mitigate. But yeah, it's a good point, and we'll bring something through to the People Committee.
Thanks, Claire, appreciated. Alison, I think you could steer us on to our next part of the performance report, please.
Thank you, Paul. We'll move on to our 3 operational divisions now then, please, and starting with mental health services.
Morning. Thank you. I'm Julie Atfield. I'm the Executive Director of Mental Health, and that's local mental health services. So primarily I'd just like to talk to the board about some issues around flow, patient flow, particularly access to beds and then access to timely discharge. So as you can appreciate with the description that you've just heard around outbreaks and staffing, it has been a very challenging time for all the services, not just inpatient but community services as well. One of the areas where we've seen some particular challenge is obviously around access, but also around the timely discharge of our patients. We've had the highest number of patients that we've ever had waiting for discharge for reasons of social care, accommodation, or waiting for complex care packages. Obviously really affected by the level of outbreaks that we've had in the organisation, but also in the broader care sector. and we've seen social care partners as well as ourselves operating at really high levels of business continuity certainly over the last month. So in response to that, we have been sort of doubling our efforts really about how we're managing flow and managing the pathway. So we have shifted since December from using the traditional sort of measurement of delayed transfer of care to making the switch to driving that flow on patients that are medically fit for discharge. So that brings in a much greater range of patients to make sure that they've got the right care arrangements and the right discharge arrangements in place. So we've worked as well to escalate that with partners and into the system, and there's a much more collective sense of managing that flow with our partners. And we are at the moment in preparation for a multi-agency discharge event that's been facilitated externally for us. So that has been a key consideration of ours over recent weeks. In response to a challenge at the last board, there's reference to page 13 on the performance report. We have looked at strategies as I was challenged at the last board around eradicating out of area. Obviously our performance has significantly improved, but the challenge is of course to eradicate out of area placements. So we did consider a proposal at the executive team about how to change the procurement of our subcontract beds in Nottinghamshire. We did actually choose though not to pursue that different way of procurement because it would potentially be generating some waste and be a really inefficient use of expenditure on the beds. So we do know that it's our work on discharge and it's our work on our own staffing and bed capacity that really will make, that continue to make that difference. And obviously there's the possibility about further capital for local delivery of psychiatric intensive care. So that's as an executive team, that's where we landed on that piece of work. And we're hoping for the publication of the external review of bed requirements for Nottinghamshire in this quarter. So that's just a bit about flow. There's an indication on the report around IAPT and not achieving the recovery for BAME service users over December. We are actually reviewing that to investigate why. So just let you know that investigation's in process. We haven't drawn the conclusions on that yet, but that would be the first time that we haven't met that target. And just could
you just remind us of the acronym IAPT, Julie?
Sorry, improving access to psychological therapies. Do apologise. And sort of lastly to flag really in terms of the context. So at the moment we've got a current workforce loss of over 9%, and it's been like that for the whole of January. So that means that we've got a lot of staff redeployed, as colleagues have already described. So I am expecting some issues in terms of our community performance through January. So it's just to flag that in anticipation, because we have been running at Opal 3 and Opal 4. So that's our operating escalation levels over the last few weeks. So I'm expecting to see some impact in community performance into January. So that's it from me. Thank you.
Great. Thanks very much, Julie. And again, just opening it up for any comments or questions. I think just to acknowledge what you were saying around the out of area challenges and the discharge challenges, Julie, they're obviously things that as a board we share your concerns around those, and just to really encourage that that kind of radical thinking and different ideas as much as you can, and just trying things out, because I think it's for some of these areas, doing more of what we've done before isn't going to crack it. I do appreciate you described there lots of different thinking that you were trying to bring in, but I'd certainly encourage that we will be behind you as a board on coming at that with whatever different thinking you think may have a chance of making impact for us. Alison, do you want to move us on?
Thank you, Paul. Can we move on to community health services, please, and over to Becky?
Thank you, Alison. Good morning. Becky Sutton, Director for Community Health Services. So acknowledging and not going over all the points that people already have around the challenges that we had in December and into January, seeing a similar picture in community services. There's probably one bit of context that's been a little bit different for the community, and John spoke about earlier in terms of the national level 4 response, and actually nationally we've been asked to focus our services in 2 areas that probably has impacted on community health services a little bit differently than the other 2. So they were around deployment of staff to help with the vaccinations and the big programme that we had before Christmas, and also around, again, in a similar vein to Julie, our community services around supporting patients along the urgent care pathway and facilitating them out of hospital. So with that in mind, some of our planned care services, which are subject to our 13-week wait target, we have seen that we've had to stand some of those down to support the other areas. So whilst in December we did see the number of patients waiting over 13 weeks decrease, I do envisage that that will go up in January in response to helping out our system partners. But obviously in the grand scheme of things, the numbers are quite low and the majority of patients we do get treated within 13 weeks. The other indicator on the IPR that you can see are the new urgent care community response indicators that I've spoken about now for a couple of months, where again we're supporting keeping people out of hospital. I'm really pleased to announce that we're seeing 96% of patients within 2 hours, and we're able to respond within 2 days to help care at home. And what I will acknowledge that the volume of patients we're seeing through that service in response to our urgent care has increased. So I think last month we talked about 180 patients we stopped going into hospital. In December that was 279. So a huge thanks to the ability that our teams have responded to that ask, often working in areas that or changing the way they've worked and being deployed into other areas. Is a huge thank you from me to our community services and people willing to give vaccinations in those last few months as well. We are seeing those staff return, and we are reviewing our derogations, which I'll come on to a paper later. The only other bit that I'll take as read on the report is we have a number of local incentive schemes that again are between us and our commissioners, and you will see unfortunately a number of those we haven't achieved for the last quarter, but mainly on the issues that we've already talked around derogations of staff and the way we've had to work things differently in the last few months. So I wasn't going to go into a lot of detail, but very happy to take questions.
Thanks, Becky. Carolyn, I'll bring you in, please.
Yeah, thanks. Thanks, Becky. A lot to be proud of in there, given the circumstances that staff are working under. My questions are related to podiatry, particularly because we've heard a very positive story today, and I think it would be helpful to understand, although there's a relatively small number of patients waiting, I think it says 60, how long the longest waiters are within that, just to give us some context, because if it's whatever 19 weeks, that may be not a problem, but if it's much longer, then that does give us cause for concern. And then the other area was around the local incentive schemes and whether there are any financial implications for us for not meeting those targets.
So I'll start with that question first. So no, there aren't, Carolyn, and actually a number of those local incentives, as we start to move forward into our transformation programme about community services, I think we can have a much more outcome focused approach to them. So a number of those are quite historical. They've been in place for a number of years, and I would perhaps argue they're not the best measures of patient outcomes. So I'm really keen to move on to a different conversation with our commissioners down the line around really being able to define the difference we make to our patients in community, but there is no financial issue with those. And I think you make a really good point about podiatric surgery. So great story. We did potentially for a week look at just prioritising our patients in podiatric surgery around derogations and deployment, but apart from that their services have run as normal. The reason we've seen the waits increase was around sickness, around COVID. So I will come back to you with exactly the longest wait for next month and that profile, but I do know we got those waits back down in the summer, so I don't envisage any of those patients will have waited a huge amount of time, and we certainly haven't got any of the 50 to 104 week waiters that our acutes would have in terms of, you know, a year plus that people have been waiting for care. The other thing I can assure you with, as part of that wait, we do then re-see those patients in a priority order. So whilst they might have waited a little while, we make sure that the patients that are a highest surgical priority are seen first. But actually, as I say, I do know that's only built over the last month or so, couple of months. So I don't think patients, but I will bring you back next month a whole detailed report of waiting times by weeks, Carolyn, if that's helpful.
Thanks, Becky.
Great, thanks Carolyn, and you certainly picked up the questions I was going to ask as well. So Alison, I think steer us on, please.
Thank you. I'll hand over to Sue now for forensic services. Thank you.
Hi, Sue Alcott, Forensic Director and Medical Director. So first of all, I need to thank all of my colleagues in the Forensic Division, firstly, because this is probably the most difficult period that I think, talking to colleagues, we've ever been through, actually, as already been talked about. Highlight a few things before we go on to questions there that I think the board need to understand. So the Forensic Division had two main cases of pressure. So the first was Rampton and the second was Arnold Lodge in Leicester for different reasons. And because of the number of outbreaks and the number of staff that were unavailable to work due to COVID directly or due to isolating, not COVID being ill, that shot up in December. So our staffing availability, given that our bank is internal, was significantly challenged, and that's been a big issue for us. Because of that, we went into Silver Command and we implemented daily forensic incident control meetings from that time in December, and we've just finished and come out last week. The reason I highlight that is a lot of very difficult decisions have had to be made, and I think there's been a comment already, for example, about stopping activities. We were really clear that we didn't want to do those, so we met daily across the whole division, and we talked about any derogations that would be needed. What we did originally in the first few days was agreed principles, so that there was a hierarchy of contingencies that would be worked through before the sort of more potentially impactful situations could arise. So that helped each of the sites to keep to managing similar principles. And one of those key principles was about equity of access to treatment. So to give an example, it might be that if you were to lock down one ward, that would release more staff in particular. But what we were clear about was that would not be fair and equitable. And so if we had to do anything, it would be about managing the equity. So for example, it wouldn't be that patients who are in long-term segregation would, as a whole scale, not be coming out of segregation, because that wouldn't be fair and equitable. So anything that was being done as a contingency was on that principle. We also have a clear different model. So the comments about access to treatment and activities, we were already in the division, and particularly in Rampton, where historically those sorts of activities were done off-ward in activity areas. We were changing that model anyway, which has actually worked very well for us in terms of timing. So it's much more of an in-reach model. So staff have also been amazingly supportive about redeployment. across the division, particularly again, as I say, at Arnold Lodge and Rampton. And in particular at Rampton, the AHPs have been working in towards, but one of the first levels was that whilst they're in the ward and part of staffing numbers, they were also trying to prioritise their normal work in the ward anyway with the patients, which I think is quite important that was a principle. I've also had other disciplines, so particularly I want to thank the other disciplines across AHPs, and then some social workers and some psychologists at Rampton went into wards and did shifts. We were looking at redeployment across every single level up to and including my deputy director, the director of security and the associate director of nursing as key clinicians at this time. And I think general managers who were nursing staff went in, some did night shifts. So everybody was all hands to the pump to make this as safe as possible for patients and staff, because, you know, we need to highlight the safety of staff. So I'll just address the sickness because I think there is a key thing to understand. So we have got underlying high levels of, I think it's termed normal sickness in the report. And we need to understand that. And the reason, the highest reason is anxiety and stress. And on the back of 2 years of this, I can perfectly well understand why people are feeling like that. But because our COVID sickness and then secondary, our isolation of staff, it nearly tripled in December compared to normal. That's why when the report's been put together, it highlights those reasons. But it is on a high baseline. But then because this drastic peak, when we were measuring our staff available to actually help and support, we weren't in a position that we would be normally. Staff were really good. We never got to the point of saying people couldn't take their planned leave. We didn't have to get to that at all, which was really good. Some colleagues did cancel leave and chose to do that to help keep the ward safe, which was really positive. And I have to say, the patients really appreciated that as well. We are mindful and obviously are monitoring in terms of complaints, SIs and things like that. So far at this point in time, we haven't seen anything that would raise any concerns. Obviously that will continue, noticing the lag effect. I think I'll probably stop there. I hope I've covered some points.
Great, thanks, Sue. And I really welcome your getting into a little of the detail around what staff have done over this period, but also your acknowledgement there about trying to tackle some of that underlying, as you put in quote marks, normal sickness and the context for that. And I appreciate you bringing that to the fore. Just see if any questions coming through. Stephen, please.
Good morning, Stephen Jackson, Non-Executive Director. I think I need to apologise. I think my camera is struggling a little bit, so I'm edging over to one side of the screen. It's around page 6 of the integrated report, and the invalid mental health detention, Sue. I wonder how long it takes us to find an invalid detention. You know, do these take days, or do we have anything more serious?
Rather than try to answer that in detail, if you're content, I'll take that away and get more information. From the information that we look at in terms of the Mental Health Legislative Committee, get my teeth in, it really varies because it depends what it is. So all the Mental Health Act papers are checked at the time of admission. So if it's something simple like, it's written really, or somebody's written the wrong name, that seems to be sometimes common. But then also some have been found much further down the line for other reasons to do usually with transfers from other hospitals. So it's quite a variety, but I'll get that taken through log and we'll look at it in a bit more detail.
Okay, thank you. Thanks, I'm content with that, Chair. Thank you.
Thank you. Carolyn, please.
So I was just going to comment on that last point. I think Sue's probably covered it. We do pick this up through the Quality and Mental Health Legislation Committee, and quite most often those reports are because of documentation of issues. the way it's phrased in terms of invalid mental health detentions suggests that we're holding people inappropriately, and that isn't the case. It is about the documentation.
Right, thanks, Carolyn. Okay, thanks for that, Sue. Let's, Alison, come back to you for the finance piece, please.
Thank you, Paul. Alison Wild, Interim Exec Director of Finance and Estates. Just to update on the finance position of the Trust as at December 21. So during the pandemic, the NHSEI's response to COVID-19 means that we continue with block contracts, and our performance against those block contracts as at December was a £2.9 million surplus. Spend is planned in the final quarter to achieve our planned year-end position, which is a break-even position, so all on target to achieve that at this point in time. Within that, we have managed to deliver a full financial improvement plan to a tune of 8.8 million, albeit some of that is non-recurrent at 4.9 million, but that's a good achievement given the financial year that we're going through. In terms of capital, we are £1 million above plan, but that's due to additional resources specifically coming into the Trust due to the Unified Technical Fund for our digital services. So although we are above our planned spend, it is funded and is in line with our capital delivery expenditure limit. So all on target with finances as at the 31st of December. I'll pause there. Thank you.
Thanks very much, Alison. And just to acknowledge that, given that at the last board, we as non-executive director to challenge quite strongly around the finance improvement programme, it is welcome. I appreciate your notwithstanding the non-recurrent, but actually that's a real achievement from where we were a couple of months back. So thanks for that. So. Just check to see if there are any comments or questions. No, I think thank you, exec colleagues, for taking us through the integrated performance report. It is, I say each time now, that it's a really important piece we give proper time to. I think that has underscored the challenges that myself and John spoke about earlier on. Apologies, I have got some questions and comments coming through, but just to say that it does give us some real context, I think, underscoring the broad headlines we gave earlier. John, let me come to you and then Stephen and Carolyn, please. John.
Sorry, would you mind doing it the other way around? Because I suspect
sure.
Stephen and Carolyn might be a bit more specific to the money. Mine was more general strategic comment about the IPR generally. Thanks.
Okay, Stephen, please.
Thank you, Chair. Stephen Jackson, Non-Executive Director. Could I ask several questions, please? First of all, a sort of a continuing question that's been going on over probably most of the year. The Rampton income has now been taken out, I think 1.5 million. Does that mean that we've finally given up on chasing that, or are we just being prudent, Alison?
Thank you, Stephen. No, we haven't given up on chasing that. We are just being prudent at this point in time. And should that income come in, it will change our forecast. So we will look to talk to NHSEI about making that be for the benefit of the patients next year at this point in time. But no, definitely not given up.
Okay, thank you for that. Secondly, I know that we received income against the pay increase, but there is an adverse variance on pay. Does that mean that the income that we've received is not covering the full impact of the pay increase, or am I misreading that?
No, it's a very good question. You're not misreading. The pay award, we were short on the pay award from the national calculation to what we think we needed by 1.2 million in this financial year. We aren't sure what the position will be next year, but definitely 1.2 million pounds short for the pay award this year. that we've contained in our position.
Thanks. I just wanted to check my understanding there, but
Yeah.
so thanks very much. Again, you know, good result, really good result in terms of the FIPs that you're managing to achieve. But is part of that, I mean, we've got a favourable variance, haven't we, at the end of the last period of account. Are we going to utilise that favourable variance across the remainder of the year, or is that again a potential upside for us?
The plan is to utilise that, Stephen, at the over the rest of the year. We've got additional expenditure for the refurbishment of Sherwood Oaks, which was over and above some of our planning assumptions. So there is a plan to utilise that over the year. In terms of the delivery of the financial improvement plan and the underachievement in terms of recurrently on that, some of that unfortunately has been due to the lack of recruitment and inability to spend on bank and agency. So it is a bit of it's a double-edged sword in terms of, yes, we have managed to deliver FIP on a non-recurrent basis, but there have been impact on patient quality, safety, and the things that we've described in this board, which is not something we would want to continue doing. We need to find a recurrent solution for our financial improvement programme. So some of it is, yes, fortuitous at this point.
Thank you. And my final question, if you're pleased to know, Alison, is around capital. We seem to be forecasting to spend more allocation than we planned. Have we got all the approvals we need to overspend?
Absolutely. So in terms of overspending, it's an overplan rather than overspending, if I could just point that out, Stephen. So we have been given additional capital resources to cover our spend. If we do overspend, there is a commitment in the system, in the integrated care system, that we will stand together as a system and contain the spend in total. So yes, there is a contingency, but we have actually spent more due to the additional income coming in this year, very late on, I must say, as well.
Okay, thanks very much, Alison, and thanks, Chair, for allowing me those several questions.
No, really good to tease those points out, Stephen. Carolyn, please.
Thanks, Chair. Alison, my question is around the financial improvement plan. So whilst overall we've achieved our FIP for the year, you've said a significant proportion, over 50%, is non-recurrent. So my question is around how that impacts on our forward plan for the coming year, bearing in mind that we're in February now. So I'm looking for assurance about what we've got lined up in terms of financial improvements, schemes going forwards, and how that 4.9 million is added on to whatever our FIP is for the coming year.
Thank you, Carolyn. That's a really good question. So in terms of for the forthcoming year, we are currently working through our planning process. Now we have the operational planning guidance, and early indications look like that our FIP target will be near a 4.1%, between 4.1 and 4.3%. What we are doing as a system is looking about whether we can balance our underlying financial position over a 3-year period, which could reduce our FIP requirement to about 3.3 or 3.4% next year. Having said that, that's very challenging. In terms of delivery of FIP and schemes identified, I think there is a mixed bag over the trust. Community services have been working on transformation in the system and have achieved a higher percentage of recurrent FIP, but I think we've got a long way to go, and I think it's really high risk in terms of next year. The trust is taking some action in terms of we are advertising for a programme manager to focus on financial efficiency. The clinical divisions are obviously in a level 4 command and haven't had the opportunity or the capacity to actually focus on FIP. So that's something as our enabling services we need to wrap around the clinical divisions and support them to identify schemes in the best way we can. So that is going to be our focus in terms of our enabling functions to help the divisions identify schemes. We also need to remember that as an ICS, we are looking at some cross-cutting themes across the ICS, which should be larger schemes in terms of transformation that would help at the delivery of FIPs in organisation. For example, an estate strategy across the whole system that should help. But those schemes are also in their infancy in the system, so it's going to be a very challenging year next year.
Thanks, Alison. I mean, it does sound as though there's a high amount of risk in there for us, and an area that we really need to focus on. I'm aware that we're kind of changing our structure slightly, aren't we, in terms of leads for estates and IT, and I think my experience would suggest that if we're going to make big savings, it's going to be out of big transformational schemes, not cost cutting within divisions. So but I guess we're up against it, aren't we, if we haven't identified those at this point, because we won't be realising those savings from the beginning of the financial year. But thank you for your answer anyway.
Okay, thank you, Carolyn.
Thanks, Carolyn. I think I'd underscore that piece, Alison, as well, that you know, we need to get stuff in as early as we can, because every month that goes by in the financial year makes it tougher as we get towards the end of it. John, let me bring you in for a final comment on the back of all of that IPR work.
Yeah, thanks. And it follows on nicely from Carolyn and Alison's conversation there. So I know the IPR is about what the data is telling us, but it's a more strategic comment really in terms. There's some really good examples in the commentary we've just had that I just wanted to sort of flag to the board. There are good examples of, okay, so what do we mean by ICS? What's it going to be like in the future? What are we working towards? So whether, for example, you take the out of hours, the sort of out of area beds that Julie was talking about a few minutes ago, that there's national infrastructural money in capital to fund those. We've been successful in getting some of that funding, but one of the big changes within the new governance structures and frameworks is that's not strictly ours now. It's not just ours, it's part of a system capital amount, and that has real impact on how we go around influencing and working in the system to enable us to keep hold of our allotted amounts. And there's sort of similar conversations about money in terms of something called the Mental Health Investment Standard, which we've been really successful in working with our commissions in the system, but there's other systems where there's all sorts of pulls on that money to essentially bail out acute trusts who are in deficit, and obviously the national team is very resistant. But these are the sorts of issues and relationships that we need to build and develop in our ICS to make sure that, certainly from a mental health and learning disability perspective, that we can still do the business that we need to do and improve services and outcomes for patients. The point, the conversation Becky had around the local incentive schemes, that's a really good example of transactional contracts, which will increasingly, if things go well, be a thing of the past, and we can really start to focus on improvement, outcomes, patient experience. But there's a long way to go in terms of getting away from, to paraphrase, I don't mean this in a demeaning way, counting beans. There isn't really very much point, and we've really got to focus on quality and outcomes. And the last point again around Alison was describing and Carolyn around those real transformational programs. There's system asks, whether we're looking at developing and recruiting a workforce that's fit for the future, whether it's around estate or digital. We're much better off doing that collectively in the system rather than us all working individually, because we're so increasingly connected. So just sort of flag that in terms of some of the sort of strategic things out of the IPR that moves us into, okay, so what for the future then? Thanks.
Thanks, John. Helpful. So really important conversations there around the performance of the trust. I think we've given that a really good airing. Colleagues, let's take a comfort break. Let's restart at 20 past, just to give us time to have a proper comfort break, and then we'll come back in for our next item, the non-executive director champion roles. So see you at 20 past. Okay, I think we're ready to restart if we can, please. If we move on to next item, which is the non-executive director or NED champion roles. Shirley, if you could introduce yourself and the item, please. Shirley, are you there?
I don't think she's quite back in her seat yet.
Just let her get back into the room. I can hear her coming back.
I can hear her running down the corridor.
Great. Okay, Shirley, I think you're just joining us back in now. If you're not out of breath, if you could introduce the item on the non-executive director champion roles, please. You're on mute, Shirley.
Hello. Shirley Higginbotham, Director of Corporate Affairs. Sorry about that. Apologies, Paul. Yeah, so this paper is about the non-executive champion roles. The board will recall that previously we had quite a few champions for the NEDs, and it was getting a bit ridiculous. So there has been guidance, and a working group was established, of which our chair was part of it, and guidance has been issued which reduced them significantly. So there are now only 5 mandatory champion roles. That's maternity board safety champion, which obviously isn't applicable for us, the wellbeing guardian, freedom to speak up, doctors disciplinary and security management. They are detailed on the paper. The doctors disciplinary will pick up the MHPS requirements, so a NED will be allocated on an individual basis, so that won't be just one NED as I think it has been previously. All the other elements of the champion roles that were there before will be dealt with by committee, and that's detailed on which committee is detailed on the paper. So I think it's a really good piece of work that has been done to reduce the number of champion roles, because we required a NED champion for almost everything. So this brings it back down and brings it back into committee where it should be. So it's here for approval, please.
Great, thanks very much, Shirley. You've described it really clearly there for us. I'll pause just to see if there are any comments or questions. I think the paper summarises exactly where we are, and just to underscore that we will review over the next 3 to 6 months, particularly as we have new non-executives joining us. But can I just get an indication from colleagues if you approve as is, please? That's great. Thank you very much. So let's move on if we can, please. Becky, to the decisions and derogations process, please.
Thank you, Paul. So Becky Sutton, Director of Community Health Services, but also have emergency preparedness and planning in my portfolio as well, hence me talking to this paper this morning. So this is here for assurance, and this is a snapshot quarterly board paper. This has been before. That demonstrates and highlights our decisions and derogations that we've taken through our incident control COVID process from the 21st of September to the 18th of January. In the reading room is the whole list of derogations, of which listening to this morning, you won't be surprised to see there are a number in place, or a number of decisions that we've taken over the last few months, and a lot of those have been added into December in terms of what we've had to do to respond to COVID. So you'll see as of the 11th of January, and noting a number actually closed last week, but as it was of that point, we had a total of 122 active decisions or derogations in place. And you can see again, there's a number on the in the reading room that clearly articulates all of those. Just to give you a flavour of the sort of things, you've heard about some of them already this morning, but the sort of things that we've had in place for derogation, so stand down of some formal meetings to enable to free staff and managers up to respond to COVID. There's also been derogations where some team members have been asked to work into other teams, as well as standing down some non-urgent services. And again, they've all been either along national guidance or added onto the list. When we do those derogations, it does on the list state which CQC potentially could be affected by that derogation. And you will see we've put a new action in which we're just formulating, which will be in place for all the derogations by the end of this month. The risk of that derogation and what we've put in to mitigate that risk, so that it shows a really open and transparent way of our decision making through these difficult periods. It's probably all I wanted to say, Paul, but I'm really happy to take some questions if need be.
Great, thanks, Becky. I've got a comment that I'll bring in, but just pause to see if others want to say anything first. I think my comment just builds on the very last piece that you said there, Becky, about the importance over the last 2 years of us having a really clear audit trail of decisions and derogations that were taken. But it's also important for us not to apply hindsight and to always be remembering that decisions that were taken even just 2 months ago, the context of 2 months ago is very different from the context of today, let alone going back 2 years. And I think that when we get to the point of us doing that full review of how has this whole pandemic been over this period, over the last couple of years, it's just going to be really important that we remember the context when decisions were taken and what we not only knew, but also incredibly what we didn't know at the time of those decisions. And I know you're alert to that, but I just wanted to bring that into the public domain. Okay, thank you very much for that. Let's move on, if we can, to the next item. Claire, we've talked about this quite a bit, but I think it's important that we take the paper formally around the vaccination as a condition of deployment for all healthcare workers. I know we have talked about this quite a bit, but just take us through formally where we're at again.
Yeah, so thanks, Paul. Claire Tini, Exec Director of People and Culture. So the vaccination programme, mandated vaccination for health and care colleagues, has been an evolving and changing picture. The legislation came in to force. It was taken through Parliament before Christmas, and the timeframes in line with that legislation were that colleagues working in CQC regulated activity would need a first dose COVID vaccination by the first week in February, so this week, with a view to being having 2 vaccinations by the end of March of this year, and that was what the legislation set out. The work that we have been doing across the trust is to understand that and to interpret the guidance. The position that we are in as a trust is that over 95% of our colleagues have been vaccinated, double vaccinated, and a number have also had a single dose with a view to having a second dose. So we've been working through all of the information, and we've been working with colleagues to continue to encourage them and support them to access the vaccination. There are a number of records that I alluded to earlier that because of the way names and addresses are recorded on the immunisation system compared to the staff record system, it can show that vaccinated colleagues don't have a record, and so we are validating all of that data. This has been an evolving picture. The situation's changed literally on a daily basis, as has the information as we've gone through the records, so we've been working really hard to understand that. And we have been doing that as a trust in conjunction with other healthcare providers across Nottinghamshire, but also in the wider East Midlands. So the policy and guidance that we've been working to has all been the same, and HR teams have been working in step and in line with each other in terms of the approach, which has been good, because we've been able to talk through how the guidance might apply in certain situations. Yesterday there was an update by the Secretary of State, and the position that we've currently got at the minute is that the legislation that is currently in place will now be further consulted on. So there will be a consultation period, and the outputs of that consultation will go back to Parliament to determine if there are any legislative changes in place. So that was late last night. We don't have any details. I've not picked up anything this morning because we've been in the board around timeframes for consultation and what that will look like. That information will emerge through the week and we will understand more about it. So what we are doing at the minute is just continuing to communicate with colleagues directly, and we're waiting for more information ourselves, and we'll update the board and colleagues across the trust accordingly as and when we receive it. Thanks, Paul. Happy to take any questions on that.
Thanks, Claire. I'll just pause to see if there are any questions. I think we covered it off quite a bit earlier on, really. So I think it's just helpful getting that current summary, and absolutely take assurance from your commitment that we're obviously doing that ongoing engagement with all of our staff, and we'll be doing our very best to make sure that whatever is being said in the from the central government is then well reflected for ourselves, and if we need to amend anything, we will be doing that. Thank you very much. So let's move on to the reports from subcommittees. Carolyn, if I could come to you for Quality and Mental Health Legislation Committee. I think it's a verbal report on this occasion. So if I could just ask you to take us through highlights, please.
Thank you, Chair. Yeah, absolutely. So this is the December report from the Quality and Mental Health Legislation Committee. I think it's important to start, as we've heard already through the meeting, to say that this meeting was held in the context of very high work demand in operational services and the staff working under significant pressure due to the pandemic. Despite that, I think the committee received high levels of assurance against a number of areas, including patient carer feedback, our Quality First accreditation programme, Getting It Right First Time, which is a peer review programme that we're participating in, Learning from Deaths, Trust Suicide Prevention Strategy was an update was presented, our Patient Safety Report, Preventing Future Deaths and Inquest Report, Clinical Claims, Infection Control Outbreaks and Mental Health Legislation. So they all received significant assurance. There was one item where we took limited assurance, and this was in relation to our quality surveillance report. And this is because this is it's a relatively new report to the committee. It's still in development, and the committee have asked for further work to be done on capturing key performance indicators that act as lead indicators rather than retrospective reporting, alignment with the performance report that the board receives, and also inclusion of our overarching trust quality indicators. I think there were two key themes for the meeting that kind of ran through the reports. One was related to the mechanisms for shared learning from incidents and issues, and that is developing really well across the trust. And the other was in relation to COVID-19 and the impact that that has had across services, and in particular, as we've already heard today, staffing levels, activities enjoyed by some of our patients in our forensic services, and core training for staff. All of those issues we received assurance in terms of how they're being monitored and reviewed on a regular basis, and the actions that were being taken to drive improvements. And lastly, we did undertake careful consideration of the BAF in light of all of those issues. There were no proposals to change to the overall risk rating, but there was one agreement to refer an issue to the People, Culture and Inclusion Committee, which was regarding gaps in training, and to make sure that there was strong oversight in that area. Thank you.
Great, thanks very much, Carolyn. And I think you've brought to our attention things that would have been in a written report there clearly for us. I'm not seeing anybody indicating with questions or comments. So let's move on. Trevor, I think you're going to just give us a quick steer on the Strategy Committee highlight report, please.
Thank you, Chair. Yeah. Trevor Orman, Non-Exec Director. The Strategy Committee was held on the 17th of January. There were 3 areas of strategic importance to the Trust, plus an overview of the business assurance framework. So the 3 categories that we reviewed were place-based partnerships, the second was provider collaborative at scale, and the third was mental health long-term plan transformation. We were assured they were very good subjects presented. I think it's fair to say that all of the 3 strategies that are very integrated with the ICS integrated care system are at early stages of formation. So the key point being that with the impact that some of the impacts that Caroline has mentioned around resourcing of overall capacity within the Trust, NHSE and I have agreed to delay some of the critical milestones on these strategic positions from April to July. So that does give us some breathing space to actually dig deeper into some of the strategic intents that we've got. So there were no points specifically for escalation to the board. In terms of the BAF that we reviewed, there were no significant changes. So that would be my summary update, Chair.
Thanks very much, Trevor. And for colleagues, the BAF is our board assurance framework. So again, I'm not seeing any comments or questions there. Thanks, Trevor. Sue Nixon, if we could go to you for the People, Culture, Equality and Inclusion Committee report, please.
Thank you very much, Paul. Hello again, everybody. Sue Nixon, Non-Exec Director and Chair of this particular committee, which I'm going to refer to as PCE and I, given that the Chair has just explained what it stands for. I'm going to, in the main, take this report as read, Paul, although I would like to highlight a couple of things. As we've already learned from today's meeting, most of the issues during this challenging time have been around vacancies, staffing, redeployment to help out fill the gaps, the sickness issues around COVID. Therefore, it was a slightly curtailed agenda, but all the items were very meaty. I do want to pick up in particular the fact that the issues about getting people into post in the recruitment process, a piece of work had been done, and the team were pleased to believe that the recruitment timescales now have been reduced in terms of getting people into post. I would also like to raise the importance and good work that's been established in setting up a newly reformed LGBT staff network. The issues around Guardian of Safe Working are clearly contained, and that was particularly good. We've already seen on the agenda earlier about the project approach to international recruitment, so I won't go into those details because we've discussed those, but it is really important that I bring the next 2 items to the board's attention. The key one being the issue that we've heard a lot today about staffing issues. It is a problem across the whole of the Trust. You've heard from Claire the number of issues that are being looked at to try and get staffing into post and so forth. However, when it came to looking at everything across the BAF, we felt that we had to support the point that the risk index in the BAF needed to be increased to high 16, and that's contained in this report. But that's important for the board to realise, and I think the agenda today has helped highlight the issues around staffing, vacancies and the work that's being addressed to look into this. All the other areas did receive assurance as far as the BAF and everything else was concerned, and we were satisfied that a lot of work was going on. I do have to add, however, I am sorry, I seem to have missed off, and I don't know how come. We did have the deep dive into Highbury. Board had asked us to look into that, and I would like to thank Julie Atfield for the report she presented, and we had quite a detailed discussion about that. The key point being, even though there are a lot of issues, there's a huge amount of work being done across all the areas, masses of staff effort to try and help. Julie and her various members of her team, plus other people from other parts of other divisions, and also supported very, very strongly by John, our Chief Executive, are really making sure that a huge amount of work has been undertaken to address some of these issues. So at that point, I need to say that the committee received assurance that there was a lot of work going on, and we hope that as time unfolds, we will get some fruition from that. Those are the key points, really, Paul.
Thanks, Sue, and I think you've described some of the assurance that we seek outside of the board meeting for those issues that have been a key theme for us today. So, Trevor, if we could come back to you for the Finance Committee report, please.
Thank you, Chair. The Finance and Planning Committee was held on the 27th of January. We covered 6 particular areas of finance and planning, plus the business assurance framework. 3 or 4 of these have been previously mentioned throughout today's call. Firstly, our trust financial position, which Alison mentioned, we're targeting a break-even position at year end, which is an excellent result when you take into consideration the turmoil and disruption that the trust has had to counter throughout the past year. So quite exceptional results. In terms of capital, we're still dealing with Sherwood Oaks challenges and the big focus on digital and making sure technology grows at the rate it does so that we can manage the trust in a more modern way. Both of those are coming together, and we will manage to hit our capital targets. The third one was around the financial improvement plan, which both Caroline and others have mentioned. The critical bit of here is it's excellent news that we're on target to hit the £8.8 million, albeit non-recurring. But as John, our CEO, mentioned, to hit the future challenges will be more of a bigger system change than squeezing the orange harder within our own trust, which is realistically not viable. But there are opportunities, and we were assured of the opportunities going forward of a more system integrated improvement plans. The other areas that we covered were obviously the annual plan, as it's now part of our planning process. It's changing like the wind, but we're having to make sure that we keep on track with the demands of NSE&I. But those changes are not dictated by us; they're given to us. So we're adhering to what comes from NHSE&I. We also touched on the international recruitment, which is a reflection of some of the strategic changes that we've got to make to get ourselves in the right position. And lastly, around internal audit, where our audit company that we use, 360 Assurance, are having the same issues as COVID and restricted capabilities, but we're assured that it's not going to have any major issues on the trust. The critical items will be audited. And finally, we reviewed the business assurance framework, the BAF, and there were no significant changes. So nothing of significance to escalate to the board, Chair.
Thanks very much, Trevor. Again, I'm not seeing any indicators for comments or questions, so thank you for that. For the next item, the Council of Governors Highlight Report. Stephen, if I could invite you in to present this, because at very short notice you stepped in to chair it as I was dealing with a family bereavement. So if I could hand across to you, Stephen, please.
Thanks, Paul. Stephen Jackson, Non-Executive Director and Vice Chair. According to my screen, my camera's gone completely blank, so I do apologise. IT are on the case, but it looks as if you'll have to just manage with voice alone. I should say, Paul, it was a good meeting. It was well attended, and as usual, we got a range of good and excellent challenging questions. So I think it was a good session for all those attending. There were a few decisions were made, which I think it's probably just worth recounting for the board. The Council of Governors did approve the 4 recommended NED appointments that you talked about earlier in the meeting, Paul. There was also a renewal of 2 NED colleagues, Caroline White and Trevor Orman, who were both renewed for further 3-year terms to 2025. And we also put forward a proposal to extend the contract of the Trust External Auditors Mazars, which was extended for a further 2 years to May 2024. So happy to take any questions.
Thanks very much, Stephen. And I'm not seeing any coming through there. It's really good to see the breadth of engagement with our governors that took place during that meeting. Thank you. So I've not had any other urgent business flagged with me. So colleagues, let's just take a couple of minutes to review the meeting, particularly in the context of our values and any reflections that anybody has. I would like to hear a couple of reflections if possible, please. Carolyn, you've appeared on my screen, so I'm going to come to you. Carolyn.
Yeah, Paul, I just wanted to say how much I enjoyed the patient story at the head of the meeting. I think it kind of set the context of what we're all here to do. And I did put a comment in the chat bar there just to say that right at the beginning of the meeting that I suspect this is what our staff do on a day-to-day basis. This is just their bread and butter. But to hear that reflected from a patient's point of view, that really reflected care, compassion, commitment to our patients in the context of all the hard work that is going on through the pandemic was really heartwarming. So just wanted to say thank you to Becky and the team for that.
Great, thanks, Carolyn. Trevor.
Yeah, on a similar vein, Chair, I think it's worth just recognising the efforts and the work that the exec are putting in to support the direction of travel for the trust. The grounds that they have to, the breadth that they have to cover and the depth of knowledge that they require to keep everyone on track, that channels through and supports the comments that Caroline's just made, are essential. And I'd particularly like to just warm thanks to Alison for once again stepping in and doing a first-class job as interim finance. It makes such a difference when you've got confidence in critical roles of leadership that you know are going to work okay. So my thanks to the exec particularly.
Great, thanks very much, Trevor. I think my Stephen, let's bring you in, please, Stephen.
Thanks, Paul. Stephen Jackson, Non-Executive Director. Fully support comments of my 2 colleagues, and just to add again that in spite of all of that, we're producing a fantastic set of numbers, achieving all of our targets, spending what we need to do on capital in those circumstances. You know, is a really great effort across the entire team.
Thank you. Sue Nixon.
Sorry, Paul. Sorry, Sue Nixon. Just in terms of reflection of the content of the meeting, I actually thought the discussion around the IPR was very good. And I thought we got similar trends of issues and concerns across a number of our items raised today. But we heard of the various works and pieces that are being done to try and reconcile and get us back on track. So I thought that was very positive, and clearly I support all the comments of my my colleagues' previous comments, but in particular, again, I would wish to say thanks very much to all staff, because I think they're doing a tremendous job despite the very, very difficult circumstances and winter pressures too. Thank you.
Thank you, Sue. My final comment is just to reflect that it does feel like, having had this 2 years of very much COVID focus, we are starting to emerge and really starting to be able to bring our focus back to some of the things that have had to slip back a little. And I think that over the next couple of months, I'm looking forward to, as a board, conversations that we're having really ramping up again into some of those other non-COVID related areas of work. Not that we weren't talking about them today, but I think we will hopefully see a shift back in our focus. So thank you very much, everybody. Board colleagues, if we could start our part 2 at 12 o'clock, please. And we need to rejoin through another link. Thank you for observing if you've been able to watch us, and we look forward to coming back again next month. Thanks very much, everybody.